Bonjour tout le monde, je pense qu'on va pouvoir commencer la session. Hi everybody, we are able now to start the international webinar dealing with total hip arthroplasty. I would like to warmly welcome all of you. You are coming from several countries. Again, I will say the name of the countries again to welcome all of you. You are coming from Australia, Argentina, Iran, Israel, Morocco, Tunisia, Switzerland, and France. Thanks a lot to all the speakers tonight. They are all users of our symbol total hip system, and they are coming from Argentina, Tunisia, Switzerland, and France. I will ask Professor Wangeras, who is working in Lyon Public Hospital, to make the introduction. If you are all of you ready, we can start this international webinar. So, Professor Wangeras, you can start. Thanks a lot, and enjoy this meeting.
Thank you, Ludovic, for this introduction. So welcome for everybody for this good meeting. For several topics we will discuss with about a symbol total hip replacement system, and I hope you enjoy all the topics. At the beginning, I will give the talk to Dr. Chatin. He's working in Clinique Beldon in Grenoble, France. So, Frédéric, you can start, perhaps.
I'm ready.
Let's go.
Okay. Hello, everyone. I'm very happy to start this first international webinar about symbol range. And indeed, I live in Grenoble. It's the French capital Alpes. And this place, the Winter Olympic Games took place in 1968 in this town. So my topic is about the mode of failure after total hip replacement, and what can we learn, what can we know, and what can we learn about that. Next. Indeed, and that suggests the underlying question is why do we have designed or developed a new total hip replacement? Next. Indeed, most often of time we are very proud of our post-operative X-ray and about total hip replacement and the result, the clinical result. And total hip replacement has been elected as a surgery of the century. Next. However, whatever improvement of techniques and concept, there is an inescapable overall rate of revision all over the years and in every country. Next. As you see, the four main causes of revision after primary total hip replacement in every country all over the world is first loosening, second dislocation, infection, and periprosthetic fracture. And the order is quite the same in every country. Next. What we know about aseptic loosening. Most often of time, it's wear of polyethylene which leads after to osteolysis. About 15% at 15 years follow-up, about 20% to 30% after 20 years follow-up, and about 25% to 40% after 25 years follow-up. And we know that it's multifactorial. Next. There is another kind of aseptic loosening. It's a partial loosening. It's called stress shielding. Stress shielding is very well fixation to the distal part of the stem and no fixation to the upper part of the stem, as you can see as the X-ray. And there is some studies shows clearly that there is a mismatch between proximal anatomy of the femur and the stem. And one of the study, a recent study in 2016 shows there is a mismatch in 30% between a very common and popular uncemented stem, the choroid stem, and the proximal anatomy of the femur. Next. So the question that suggests is what is the best between metaphyseal fixation or the tripon fixation? And we have to keep it in mind for the following speaker. There is also an early fixing failure that is not a loosening, that is not a stress shielding, that is not a bad primary fixation, but we have to ask ourselves about maybe our technique, maybe about the ancillary. Is it a good adequation between the rasp and the implant you use, or maybe because the implant, the shape of the implant, of the design of the implant is not so good. Next. What we know about dislocation. Dislocation, it's maybe the first concern of the patient, and it's the second cause of revision after primary total hip replacement. And as you see on this diapo, in France, we have the lowest rate of revision for dislocation. And I want to give you the French secret. It's because we have used for a long time the dual mobility concept. Next. Indeed, the dual mobility concept is maybe the solution to prevent and to avoid dislocation after total hip replacement. And this concept is not only reserved for hip revision. You can use it for primary total hip replacement. And Professor Guyenne will develop and in detail this concept we have optimized. Next. And the question you have to keep in mind for the next presentation is why to use a non-hemispherical cup if you believe in dual mobility concept, because it leads to adverse effect. As you can see on this X-ray, there is an impingement between the neck of the stem and the rim of this cup, which is okay. We can see it's not in a very good position. Next. I show you another case, and it's one of my personal case. I'm not very proud of that. I'm not Donald Trump. I put this stem in a little varus, and with a retroversion, I make a double fault because technical. It's a technical fault, and the second fault I don't choose a good implant because cup is a so-called anatomical cup, but in French and in reality that means it's not an hemispherical cup. So there is an impingement I discover when I re-op this patient, which has never forgotten his hip. I discover a huge metallosis, and there is an impingement between the stem, the neck of the stem, and the rim of the acetabulum of the cup. Next. What we know about infection. Infection is a first concern of every orthopedic surgeon, and we believe that it's easier to remove a shortened stem than a standard one or bigger one, of course. And maybe we can think that it's a good idea to decrease the material for primary hip replacement, but also for secondary hip replacement, because we believe in de-escalation, and in order to decrease the rate maybe of primary or secondary infection. Next. Next, please. We know also that time of surgery contribute to the risk of periprosthetic joint infection. And the minimally-invasive approach can contribute also to the time of surgery and so to the risk of infection. Next. What about periprosthetic fracture? Next. We know that it's very more common with cementless stem, and it can occur during the surgery, and that suggests the reflection that a good technique and accurate ancillary and ergonomic ancillary can decrease the risk of periprosthetic fracture. Next. What about bad result because of residual pain? Of course, most often of time, every time I should say it's because of surgical mistake. The offset decrease, the leg length discrepancy can be a cause of residual pain. Next. In this, now we well know the impingement, possible impingement and an overhang or overside cup in front of the acetabulum. And some paper shows there is 0.5 to 5% of this kind of problem, and we have to keep this in mind, this problem, if you use a non-hemispherical cup, for example. Next. Another case, it's not my case. I'm not the worst surgeon of my town, but I follow this patient. I have not yet re-op. This patient has been operated in 2011. She has never forgotten his hip. And 8 years after, you see on the neck a mark that is a sign of an impingement between the cup and the stem. Next. So this is our goal, is to try to reduce all this problem, and that is what the following speakers are going to speak and to explain to you how we have tried to succeed to reduce all this problem. Thank you very much for your attention.
Thank you, Frédéric, for your topic. And now I will introduce my friend Olivier Guyenne, Professor Olivier Guyenne. He was working before in academic hospital in Lausanne, and now he's working in Clinique Montchoisy in Lausanne and 2 in Clinique de Genolier in Genolier town. He will speak us about the design of the symbol hip arthroplastic system.
Thank you, Frédéric. Hello, everyone. It is my pleasure to present the design rationale of the symbol total hip arthroplasty system and to share with you the biomechanical principles that led to the development of the symbol system. So the statement of work that led to the development of the symbol system was based on 3 main goals. The first one is to optimize the mechanical operation, not only regarding the cup-stem couple, for optimized range of motion free of impingement and stability, but also regarding the periarticular muscles with restoration of the center of rotation, as well as the offset and the leg length. The second goal was the optimization of the bone fixation while preserving bone stock. And the third goal is the optimization of mechanical operation and bone fixation for all of our patients, despite the variety of morphotypes. Next. The symbol stem has been designed in order to achieve consistency between the intramedullary parameters and the extramedullary parameters. Next. Intramedullary parameters are critical in order to achieve a primary stable fixation, which is the prerequisite for osteointegration of cementless implants. And for this reason, the symbol stem has been designed to match the proximal femur morphology in order to optimize the primary press-fit fixation. And this will determine the size of the stem and the level of the bone cut. Next. Extramedullary parameters will allow to control the center of rotation, the offset, and the leg length, and these parameters are closely related to the intramedullary press-fit fixation. Next. Data from literature suggests that the anatomy of the proximal femur is highly variable, as ethnic factors and geographic factors have been shown to influence the proximal femur characteristics, such as the neck shaft angle and the femoral offset. Next. Other studies have emphasized the proportionality between the intramedullary dimensions, the offset, and the neck shaft angle. Next. When designing a new femoral component, the goal is to reproduce the anatomical proportionality between the intra and extramedullary parameters in order to match the anatomy of the patient and allow restoration of the center of rotation. In other words, the goal is to restore the offset without compromising the metaphyseal filling, thanks to an adaptation of the extramedullary parameters to the intramedullary parameters. Next. At the time of the development, next slide, please. Thank you. At the time of the development of the symbol THA system, we performed a morphometric study including 204 hips of healthy subjects. And from CT scans, we performed 3D modeling of a so-called corrected coronal plane based on the center of rotation and the axis of the femoral shaft in order to perform morphometric measurements. Next. And this study highlighted a correlation between the proximal femoral metaphyseal volume and the femoral offset, the femoral neck length, and the femoral head height. And this correlation was shown to be independent of the femoral neck shaft angle. Next. So in other words, this study demonstrated that increasing the femoral size results in increasing neck shaft angle and offset of the head center. Next. So based on this morphometric study, the symbol stem has been designed according to the proximal femoral metaphyseal volume and with a proportionality between the intra and the extramedullary parameters, including an homothetic increase of the neck length. Next. The symbol femoral implant has been designed with an optional colored stem, and as an undersized collar may fail to prevent stem subsidence, as shown in this case, we performed investigations to determine whether specific morphotypes would require an adapted sizing of the collar. Next. So we performed a 3D morphometric study with a morphometric study with 3D modeling of a corrected coronal plane on CT scans and manual templating of the appropriate stem size on 204 hips. And we measured the cortical distance, which is called the CD distance, at the calcar site to define, that is defined, as the ideal sizing of the collar. Next. And this study demonstrated a direct correlation between the size, the type of stem, standard stem or varus stem, the head diameter, and the cortical distance. And this study suggests that the collar size should be proportional to the size of the operated hip and should be larger for varus stem models than for standard models. Next. When it comes to the symbol cup, its design has been driven by an optimization of the range of motion to impingement with a pure hemispherical design without any lip or greater than hemisphere area. Next. And such an hemispherical design for the symbol cup provides many advantages. First, it decreases the likelihood of impingement. It also decreases the risk of stress transmission at the bone cup interface. And for ceramic bearing, it decreases the risk of microfractures secondary to repeated impingement with the prosthetic neck. Next. In addition, for the dual mobility symbol cup, an hemispherical design provides additional advantages. It decreases the risk of cup malposition. It decreases the risk of metallosis secondary to repeated impingement between the neck and the outer metal shell, as shown by Frederick in the previous presentation. And finally, decreases the likelihood of iliopsoas tendon syndrome. Next. The benefit of an hemispherical design on stability becomes obvious when considering the jumping distance and also the so-called PHDD, which corresponds to the minimal distance the head has to displace to be tangential to the edge of the cup in the coronal plane. And these parameters depend on the head diameter, the cup inclination, and the cup design. Next. The hemispherical design of the symbol dual mobility cup provides the greatest PHDD when compared with a conventional cup, a modular dual mobility cup, and a subhemispherical dual mobility cup. Next. And finally, the symbol dual mobility cup has a concentric design. The use of a similar center of rotation for the inner and the outer bearings will prevent from potential mechanical deleterious effects of eccentric dual mobility systems, leading to accelerated wear and potential high stress transmission. Next. So as a conclusion, here are a few take-home messages. Next. The symbol stem design is based on morphometric studies with analysis of the proximal femur metaphyseal volume to optimize the press-fit fixation and osteointegration. The symbol stem design provides a proportionality between intra and extramedullary parameters with homothetic increase of the neck length. And the design is also based on analysis of the cortical distance at the calcar site in order to optimize the collar sizing. Next. The symbol cup has a pure hemispherical design, which provides many advantages, including optimized range of motion free of impingement and stability. And it also reduces the risk for metallosis, iliopsoas syndrome, and cup malposition. And finally, the concentric design of the symbol cup prevents from potential accelerated wear of polyethylene and high stress transmission to the interfaces. I thank you very much for your attention. Next. Thank you.
Thank you, Olivier, for your presentation. And now I will introduce Dr. Jean-Emmanuel Gédouin. He is working in Hôpital Privé du Confluent, and he will discuss with you about the biologic choice we make for this implant for respecting the soft tissue and the bone fixation. That's to you, Jean-Emmanuel.
Good evening, everyone. I'm glad to be here with you tonight. Next. After those previous talks, you understood that the symbol stem is not only shortened, its design has been developed to optimize the fixation in the proximal zone of the femur, and by this to avoid stress shielding with failure of metaphyseal bone integration. This phenomenon can be seen to worsen over time with the onset of pain in active people. Next. Sorry. It's okay. If we aim to improve metaphyseal feeling, we needed to verify it. A study by the group led by Nicolas confirmed that our stem not only allows better metaphyseal feeling, but that it does not alter axial alignment. He will provide you with additional detail on his work in his presentation. Next. In addition to its design and surface microstructure, the stem is fully covered with hydroxyapatite. Studies have shown the benefits of its use, like in the Australian registry. HA reduced the risk of revision by 17% at 10 years. And the revision rate for the same type of implants is always in favor of HAP, whether in short, medium, or long term. Next. A more technical point is about the advantage of homothetical progression of the neck. The proportionality of length of the neck with the size of the stem allows to match most cases for a same range of implants. It also aims to optimize the stress between the neck and the head. You remember that the friction torque induced by the head on the neck is always the greater as the diameter of the head increases and acts on a reduced contact surface. Home OTC will therefore make it possible to remain more often in good configuration to maintain a better contact surface between the head and the cone. Better interlocking decreases the risk of micromotion and therefore stress corrosion of the neck. Also, to reduce this risk, it is commonly agreed not to exceed the diameter of 36 millimeters of the head. Next. On the acceptable side, a well-fixing cementless cup is less efficient than for the stem. So it's important to promote the blocking of the implant by first a good press fit, or if necessary, the addition of screws. The failure of press fit leads to micromotion, which compromise osseointegration. While good primary fixation will allow HAP to play its osteoinductive goal and also fill the small bone defects. Next. In this study by Manley, we see that in addition to press fit and HAP, the lack of rough patch or porous coat alters the quality of the anchoring between the bone and the implant, and that on the duration. Therefore, the smooth cup loosens more often and more quickly. This will happen all the more quickly as the passions are active. Next. Next. So, no, next. You can go back. Okay. So, to optimize lasting fixation, we have designed a singular hemispherical cup with a progressive press fit to optimize the primary fixation. An HAP layer will play the role of osteoinducer, stimulating bone regrowth or secondary fixation. Finally, the newly formed bone will colonize the porous titanium and allow long-term fixation. Next. The design of our cup also aims to spare the acetabular bone. Its press fit proportional to the size of the cup is a progressive over thickness from the pole to the equator. This allows for economical rimming and avoid oversizing and risk of fracture. Its flattened pole avoids premature blockage in the bottom of the socket that would adversely affect the equatorial press fit. Its hemispherical shape in dual mobility configuration simplifies its orientation, and less overhang at the periphery reduce the risk of impingement with the neck or the psoas tendon. We previously said that in the previous talk. Next. The impingement between the rim and the neck exposes to the risk of fracture of the ceramic insert or of metallosis, as said previously, Fred Chatin. Details like the soft chamfers, the bright polished surface aim to reduce this risk. Next. The impingement between the overhang rim of the cup and the iliopsoas tendon is a problem that remains largely underestimated. The advantage of a dual hemispherical mobility cup compared to a classic dual hemisphero-cylindrical mobility is to reduce the risk of overhang and therefore impingement without compromising stability, as said Olivier previously. The flattened pole also plays this role by reducing the risk of internal blockage. Next. In summary, the key point of our range of implants are: the shape of the stem is adapted to the metaphyseal fixation. Consequently, the stem is shortened and adapted to the useful height for the fixation. neck homothécy covers the largest panel of favorable configuration for the same range of implants, and it's very important, the same range of implants. The progressive press fit of our cup allow very good primary fixation while being economical on the bone stock. We have opted for a roughness surface with associating hydroxyapatite on porous titanium, which optimizes tertiary fixation. Finally, the hemispherical design limits the risk of impingement with the psoas or the neck without compromising the stability in the dual mobility configuration. Thank you very much. Merci beaucoup.
Thank you, Jean-Emmanuel, for all this very important information. And now I will give the talk to Dr. Florent Delangue. He is working in the Hôpital Privé de la Loire in Saint-Étienne, and he will discuss about how we design the ancillary to make this implant.
Hello, everybody. Thank you, Frédéric. I'm very proud to talk about this simple system and explain you the importance of the instrumentation. So next. So it's a compact and simple instrument. It's an instrumentation compatible with all of choices of approaches of modularity, of fixation and friction couple. Is the same preparation step for permanent adaptability, and even during the surgery you can change your original choice. And there is only 3 baskets for stems, cups and reamers. So next. Compatibility with different approaches. So broach holder for approach, anterior approach, for posterior approach, and also the anterolateral approach. It's including a projection mark from the top of the greater trochanter and the head of the center of the head, like you can see on this picture, and attempts possible on greater, on homopathy and trochanterometer to respect the length of the neck. Next. So it's a respected neck homopathy, and you can only for test neck. No, only 4 neck are necessary for the anterior range. Next. So you can see the broach test use modular test necks to the length and the ACD. And like I told before, only 4 test neck are necessary. Next. Okay. To respect off collar length and positioning, you have the possibility to projecting the greater trochanter from the head center, like you can see with these 2 tools during the tests or on the final stem for standard or Vara collar. So you can positioning and insert this stem. Next. The compatibility with the different access routes for any type of cup, metal back and ceramic, dual mobility, impactor gripper is a shift or straight for all the approaches. Next. Like you can see, it's a single-use plate and a no-touch insert, which is very important in France and also in Saint-Étienne. System designed with respect to the concept of hemisphericity without rim of the cup. You have the simplicity and repeatability of the gesture, orientation mark for the holes of the studied versions. You have the visibility maintained around the acetabulum during positioning, and a disassembly which does not mobilize the positioning and the impact of the cup. It's a good test at the end of the procedure. Next. I will talk about the respect, precision, and the repeatability of milling. So, like these two studies, under milling by over 2 millimeters leads to exceeding the elastic limit threshold of the acetabular bone, and improper milling of the acetabulum can lead to ascension and medialization of the center of rotation by excessive depth of the acetabulum roof. Next. So we have a specific and adapted acetabular milling to anticipate and respect the progressive equatorial press fit. An oversized milling range from 1.2 millimeter for a size 44 and to 1.7 millimeter for size 68. So, as not to risk microfractures on impact, to guarantee the primary stability essential for cementless fixing, and to ensure proper positioning of the hip rotation center. Next. So, these surgical principles are compact and simple instruments, compatible with most approaches. No touch disposable plate included. Easier benchmarks for better reproducibility. Trochanterometer mark on the broad shoulder. Visualization of the perimeter of the acetabulum using the plate. Specific acetabular reamer allowing anticipation and restitution of the progressive equatorial press fit. So I hope you will try to be sure of our choices, and you will like this procedure. So thank you very much for your attention.
Thank you very much, Florent, for your topic. And now I will ask to Nicolas Bonin. He is working in Clinique de la Sauvegarde, a very well-known clinic in Lyon. And he will discuss with us about the result of these concepts and the clinical result we have with this implant. That's to you, Nicolas.
Thank you, Frederic. I'm very glad to be here with for this first international symbol and axiom meeting, and I'm glad to see everyone. So what about the results of this concept? Next slide. Well, this implant is now more than 5 years, and we have right now early results, but we're working on later on results with hopefully 5 years results. What are our indications? Well, of course, coxarthrosis, but also osteonecrosis, and this is a good indication since patients are young, and then it's a good implant to save bone for later on. Rapid destructive coxarthrosis, of course. And what about neck fracture? Well, we do use it in also in elderly people and in neck fracture. Personally, I never cement, or really extremely, I should do like 1 or twice cement a year when my or the femur is too big for the bigger stem, or if I don't feel really comfortable, but it's really, really rare. And generally, even in elderly people with very soft bone, I won't cement. I'm also very aware of the problem with the cementation and the risk in elderly people thromboembolism. What about the number of implants released since 6 years? You can 5 years for the cup dual mobility, 6 years, more than 30,000 implantation worldwide. For the ceramic, more than 6,000, and for the stem, around 15,000, should be more right now. Next slide. So the validation criteria that we focus on for the early results were the radiological criteria. We wanted to know if what we wanted to do by creating this implant was finally being able to be reproduced on the X-ray postoperatively. And we did some study about the short-term, around 2 to 3 years results right now about medical and surgical complication. With the stem, we were of course aware of periprothetic fracture since it's a shorter stem. And with the ceramic, dislocation, squeaking, and of course dual mobility, we wanted to be sure that the risk of dislocation that we could maybe think, because it's an hemispheric cup, then was not the result where what we were thinking of, that we wouldn't increase the risk of dislocation. Next slide. So this is a study we published in Journal of Experimental Orthopedics about the comparison between two stems, a shortened stem and a coral-like stem. Next slide. This was comparing 100 standard stem to the symbol to 96 symbol stem, and as we can see, the inclusion criteria were matched with age, BMI, canal flare ratio index, and sex ratio. The evaluation was back, please. The evaluation was at 2 months post-operative, and we wanted to see if the metaphyseal feeling was better in the symbol stem. Also, we wanted to check that the axial alignment was correct. Next slide. These are the results. It was significantly better for the canal field ratio for the symbol stem. And what about the stem alignment? It was there were no difference in varus or valgus positioning between the shortened stem and the standard stem. So this should probably promote a better proximal anchoring to the symbol stem. Next slide. Well, now I was focusing on ceramic, and I wanted to know at 2 years if there were more problems with this implant than the literature. So I followed 237 patients. They are all performed by anterior approach and with a minimum follow-up of 2 years. As you can see, the periprothetic fracture was perioperative of 0.8 and postoperative of again 0.8%, which is a cumulative rate of 1.7%. Compared to the literature for cementless stem, you can see that perioperative is lower and postoperative is much lower, but it's the study from Abdel is of course of much longer follow-up. So more interesting study to compare is the meta-analysis from Miller, which is at 90 days. So the follow-up is quite short, and we can see that he compared anterior approach versus posterior approach in standard stem, and to show that there were more fracture during anterior approach, and the rate even in posterior approach with standard stem was 2.4. So we could be happy with our stem that we didn't find more fracture than standard stem. So also with anterior approach, it simplifies the surgical approach. So probably this leads to less risk of fracture than standard stem. Next slide. Other failure with ceramic is the dislocation, the risk of fracture, and the risk of squeaking. We didn't have any dislocation or fractures at 2 years follow-up. We unfortunately had some squeaking. If we ask the patient, some patients can complain about squeaking. Fortunately, there were only one patient in which the squeaking was annoying. The other one just hear about it and were answering that they could hear us in some movement, but generally they were okay with that. No reoperation right now for squeaking. Compared to the literature, implant fracture on ceramic is 2.3%, and the reoperation for squeaking is quite a lot of 6%. Again, the delay, we must be aware that the delay is longer in the literature. Next slide. Finally, the dual mobility hemispherical stem. We published in Arthroplasty Today recently the results of a 2-year follow-up, next slide, of 332 patients operated by posterior approach by 4 surgeons with dual mobility. The average age is quite old, of 72 years. And at a minimum of 2 years follow-up, there were 2 revisions of the cup, one for sepsis and one for pain, residual pain. No dislocation in the entire group. Compared to the literature, again, meta-analysis of Migliorini shows that at the same delay, there is 1% of dislocation, and with the standard approach, it's more than 1%. And if we compare to dual mobility, in standard dual mobility, you can see that it's up to 0.8% dislocation. So at least we don't have more dislocation than the standard cup. Hopefully, we will probably have less impingement. Thank you for your attention, and I let next speaker.
Thank you, Nicolas, for this good result. And I think we must continue to have more results and at a long follow-up. Now I will introduce Dr. Zahra, Mourad Zahra. He's working in Trauma Center of Benarous in Tunisia, and he will talk us about clinical case study, how it is dual mobility used in Tunisia. That's to you, Dr.
Thank you.
Zahra.
Good evening, everyone. It's with great pleasure that I share this presentation with you. I begin by thanking Didian Santé and its Tunisian distributor, Ortho et Santé. Next. I will start by speaking about the history of dual mobility in Tunisia. Yesterday, we celebrated the 16th anniversary of the first dual mobility cap. In fact, the first dual mobility total hip replacement was performed on 9 of June 2005. You know that in France, it was performed in 1974, and in the United States in 2009, because of the complex American rules, or perhaps because they are not at the origin of this technology. Next. So this is the first case. We can see the AP view of pelvic of Mrs. MC, 62 years old, followed for several years for a left hip osteoarthritis, which he had a cemented dual mobility total hip arthroplasty by lateral approach in June 2005. Next. I take this opportunity to thank Dr. Mbark and especially Dr. Miledi for this intraoperative photo during the first total hip dual mobility surgery performed in Tunisia. Next. And these are the post-operative X-ray and the X-ray at the last follow-up. We can criticize an imperfection in the acetabular cup position without any clinical consequence. Next. Since 2005, and after the marketing of dual mobility in Tunisia, The indication were those recommended by the French Society: patient with high risk of dislocation and total hip revision. For the age of patients and considering the survival rates of dual mobility cap at this time, we used them in patients above 60 years old. Next. Recently, and based on the good results of the dual mobility cap published in the literature, the indication have clearly increased, especially for younger subjects. For example, in Tunisia in 2019, the dual mobility cap was implanted in 50 to 68% of cases. Next. After this brief review of the history of dual mobility in Tunisia, here is the clinical case that I want to share and to discuss with you. She is a 65-year-old patient with a BMI of 33 and operated in November 2020 for right hip osteoarthritis, for which he had total hip arthroplasty by posterolateral approach. We didn't have any information on the operative report. The patient was transferred to our department in March 2021. Next, please. At this stage, what exploration are you asking for? With this X-ray. Next, please. We all agree that we need at least an inflammatory test, which was normal, and CT angio allowed us to study the bone defect and the proximity of the iliac vessel. Next, please. And on the CT scan, we were surprised by the bone lesion. Neither the anterior column nor the posterior column of the acetabular was fracturated. There was only a fracture of the quadrilateral surface and a defect on the acetabular roof, like we can see on this video. The iliac vessels were far. Next, please. For more information and better planning of the surgery, we did 3D reconstruction as we do for acetabular fracture. This allowed us to better analyze the situation and to understand that it was impossible to extract the cement and the cap through the posterolateral approach without fragmenting the cement, which would be dangerous for the bladder and vessels. We can see that 2 acetabular column was intact. Next, please. So after these explorations, what strategy do you propose? Which approach, 1 or 2 approaches? How to remove the acetabular cap? How to reconstruct the roof defect, and which implant you choose? Next. For this case, we have chosen to make 2 approaches. Firstly, STOPA approach to extract the acetabular cap, and secondly, a posterolateral approach for revision. Next, please. The first step was the STOPA approach. We founded the induced membrane around the cement, which facilitated the dissection and extraction of the acetabular cap. We didn't find corona mortis anastomosis, which is only present in 60% of cases. Next, please. And at the end of this approach, we put on the supraperitoneal plate to strengthen the quadrilateral surface and avoid an acetabular fracture. And before finishing the first approach, we perform a C-arm to check our osteosynthesis. Next, please. The second step was the revision of the total hip arthroplasty through the posterolateral approach. So we did without difficulty an extraction of the stem and some cement. Then we grafted the roof defect by iliac crest below an acetabular reinforcement. And finally, we cemented a dual mobility cap and a short stem. Next, please. The post-operative care were simple, and currently at 3 months as post-operative, the patient is satisfied, walked with full weight bearing, and the X-ray shows that nothing has changed, even if it's still early. Next, please. So in conclusion, for primary total hip arthroplasty, we need to master technique and the implants. In case of revision, we must plan well in order to prepare the appropriate implant and not to be surprised during the surgery. And here the indication of dual mobility cap is evident and no longer to be discussed. Next. And thank you all for your attention.
Thank you, Dr. Zara, for these very impressive cases. Now I will give the talk to Dr. German Vial. He's working in British Hospital of Buenos Aires in Argentina. That's to you, Dr. Vial.
Okay. Thank you for the invitation to participate in this meeting. Next. As we know, Sir John Chanley introduced the low friction arthroplasty in the 60s. Dislocation and the infection are the most frequent complication in the total hip arthroplasty. Next. 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 Okay. In order to reduce the risk of dislocation, one option are dual mobility caps. Tabori Jensen's study has been shown the use of radiostereometric analysis to measure the early migration. It's demonstrated that cemented-less cap migrated more in patients with low bone mineral density, whereas cemented cap were stable for 3 months. Next. Schneider et al. Recommend the use of cemented dual mobility caps in patients with moderate acetabular bone defect, early failure, or cementless bones impaction or revision in associated with reinforcing ring. Next. Hyena have reported good results using the cemented dual mobility caps in acetabular defects up to Paprosky 2C. Next. The Nordic Arthroplasty Registry Association showed that the use dual mobility caps has lower risk of dislocation and revision. However, it has a higher mortality rate than total hip arthroplasty. Next. Jean-Louis Proudhon et al. Recommend dual mobility caps in dislocation, revision, fractures in the elderly, neuromuscular alterations, and poor bone stock. And now we show our cases. Next. Next. This is our first case, our first patient, 78 years old, a female. She has these comorbidities, and she is independent for the activity daily life. She has a hip fracture Garden 4. If you look the left hip. Next. This is the video. Run. Okay. This is the video. It's our technique to cementage the cap it's very important. Pressure the cement to the upper part of this acetabulum. Our approach is anterolateral, and the patient is in the cubitus dorsus, and all the time we put pressure in the cement and in the cap. At the end of the cement, when the cement is gone, we end the pressure, and all the time the assistants check the right position of the acetabulum, and all the time we said we need a half moon in the lateral size of the acetabulum. Next, please. Next. Okay. One minute back, Paul, please. Yes, this is the post-operative immediately. This is the X-rays control, and this is the tunnel stem. Well, next. This is the case 2. It's a female, 83 years old. This is the comorbidities. She is independent for the activity of daily life. She has osteoarthritis, 23. Next. This is the immediately post-op. Next. This is 2 months post-op. Next. Okay. This is 1 year post-op, and if you look the X-rays, there aren't any evidence of peripatetic osteolysis or radiolucence around the cap. Well, next. This is our third case. She has a genu valgum bilateral, or knee valgus bilateral, sorry, and she has an hypertension, and she is an independent of the activity life. Okay, next. She has a fracture in the right hip, garden 1. Next, in 2018, we decide put reduce with percutaneous cancel screw, and 1 month late, she underwent a conversion to total hip due to a failure, a cancellous screw fixation. Next. And we use the total hip replacement with a cemented dual mobility caps. Next. This is the X-rays 1 year, 3 years post-op, and if you look the right picture, it's a zoom picture. No evidence of peripatetic osteolysis or radiolucence around the cap in 3 zones of the Lee Chanley zones. Okay, next. This is the video with the patient walking in our service. This is it. Look the knee valgus, both knee valgus. Next. No. Okay, in conclusion, and our experience from May 2018 to March 2021, we cement dual mobility caps in 26 hips, 14 intracapsular fractures, 10 intertrochanteric fractures, and 2 osteoarthritis. We use in all cases anterolateral transgluteal approach. Our follow-up, during the follow-up, the cap has been revisited. No caps failures. Well, I changed. We have 6 patients had died from causes unrelated with the intervention. And there was 1 periprosthetic joint infection. There was started to toilet and antibiotics. Well, next. Thank you so much. Next.
Thank you, Dr. Vial, for your good talk from Argentina. And now I must do the conclusion of this. I hope you enjoy this webinar. Next slide, please. And what is it's important with the symbol system, it's that it's a real philosophy of hip arthroplasty. You see that we use a lot of cementless fixing because we like it. And you see too that we like hemispherical design of the implant. What we can do and what we can say is this implant is good for a majority of patient morphotypes. And this implant allows us to use and to adapt to all the surgical procedure. The reproducibility is very good, and we can respecting the surgeon's choice in each case. Next slide. The second point is that the system is very easy to use, and you see that there is only 3 baskets, and it's very easy for young surgeon. It's easy too for the nurse because you don't have to need too much ancillary, and it's very modular, and you can use this instrumentation for all the approach as you see. Next slide. So for this implant, for symbol implant, the question could be, is this implant suitable for all indications? What you show us, and I hope you enjoy all these topics, is that we can use this implant for all the indication. And what about the clinical result? You see with the talk of Nicolas that we have good results, and these results that's a short follow-up at the moment, but all the paper we have done is very encouraging about alignment. We don't have many complications about the choice we have taken in the past, and we see that the good result of dual mobility is always good. We can say that this implant is young because it's not an implant for more than a decade, but a lot of studies are coming because all the surgeons of the groups are taking in charge the results of their patient. So I hope you will have some questions, and I hope you can give you some more information about your this implant and the results. Raise your hand, and so try to.
We have a question for Dr. Tahir Raziam in Iran. He thanks so much for the presentation. I think it's a question for Dr. Viale. How much is importance of using cage in cemented cups? Or everyone?
Okay, it's important when you have a bone defect, or if you lost the posterior or anterior column, In this moment, you need a cage. And you need the dual mobility cap cemented in this moment, because it's impossible put one uncemented cap.
Can I ask you a question, Dr. Viali? You hear me?
Yeah.
Yeah. Just wanted to know your technique for cemented. I've seen how you put the cement. You showed that very, very well, but I wanted to know if you do like we used to cement simple or mobility, you know, with 3 plugs in the bone, one in the roof and one in the ischial and ilium. Or do you just put the cement on the spongious bone?
Can you repeat, please?
Do you make holes, you know, in the ilium, ischium, and the
yes, I understand. Well, routinely I use two holes, one to the iliac and one to the ischium. Every surgery, my technique in Argentina, we use 4 millimeters more than the cap when which I use.
So you mean,
okay? Yes, I rim 54 and use the cap 50, because when the elasticity of the cement is different when you use polyethylene in the cap and metal back. It's different, and you need more cement, because we need the transference of the forces.
This is very interesting, and I would love to see results in a longer term.
I show you.
I think we have another question from Dr. Gardino. He wanted to know if we use dual mobility primarily in young patients with high labor. I will ask the question first to Nicolas and after to Olivier to give the answer about this question.
My answer is that I really like ceramic, so I use ceramic quite till 70 years old. So I don't use dual mobility, but in Lyon and even in Saint-Etienne, it's the berceau, as you saw, of the dual mobility. So many surgeons use dual mobility to any patients for a long time. So that's the answer. Olivier.
Olivier. Olivier, your microphone.
Sorry, can you hear me? Sorry.
Yeah.
This is a very good question, because it is currently a hot topic in the field of hip arthroplasty. In my practice, I have almost similar indication as Nicolas. I like ceramic on ceramic bearings for young and active patients, and after 70-year-old, I use routinely dual mobility implant. But sometimes I can use. I would recommend to use dual mobility in young patients in case of risk for dislocation. And in some very specific activities with high risk activities, such as hiking or sailing, probably I would recommend dual mobility. But otherwise, I like ceramic.
I think I'm like Nicolas and Olivier. I make the cutoff about 16 years, and I think we have the same practice.
I can.
Frédéric, I think Frédéric has another option.
Frédéric, yes.
Yeah. Be very in dual mobility. So I use it for 90% of my indication, even for patients less than 60 years old, even if they, as you see, I live in a very place where there is a lot of sport activity with skiing, mountain, etc. And I was very concerned by the risk of dislocation. And before my practice was at the beginning a posterolateral approach, and I want to secure my practice and the sport practice of all my patients. So I use a lot of dual mobility, even in primary total hip replacement. And I have presented 2 years ago to the Lausanne meeting of dual mobility a series about 10 years follow-up for active patients for practice less than 60 years old with 10 years follow-up and no dislocation and no reoperation because of wear of the polyethylene. So for me, it's very interesting and maybe the perfect total hip replacement because no short adverse effect as squeaking or anything else. And about where I still waiting to have a patient to have to re-op him for wear, and it's not the case at that moment.
Yes, I very agree with Frederic, and I'm from Saint-Etienne, so I must be agree, but I use a lot of dual mobility because I'm very confident in dual mobility, and I'm like Frederic. I don't like squeaking, and sometimes it's yes.
Very disappointed.
Yes, very disappointed. So I use a lot of dual mobility. Yes.
As you can see, Frederic is becoming in the dark.
Yeah.
It's going to the dark side. No, but the point is the of this debate is not dual mobility. The point is polyethylene.
Yes, I think the polyethylene will be better in the next years, and I think it will change our habit.
We have to optimize the polyethylene. Then if the polyethylene, if you have an excellent polyethylene, dual mobility is not an issue. It's nearly as good and even better than standard mobility. Well, simple mobility. No other questions.
And in younger people, you prefer put a ceramic head or an inox head, the classic? I think that it's better to put a ceramic head when we do a dual mobility in younger people.
Yeah, we agree.
Okay.
There is a question on the chat from Maktouf Jihad. What's the advantage of a short stem?
It's not a short stem, it's an optimized stem.
That's the point. It's an optimized stem. No, it's for my point of view, it's much easier to use. Whatever the approach, when you get smaller approach, or if you have a big guy very strong and you need to put a total hip replacement in this patient, it's much easier with this kind of stem, and the X-rays are just perfect, and so I think it will be the next standard in few years. You should know that the length of the actual stem is just the length that someone decided in, well, it was Charnley and all the others. He did the stem that worked. So the length, they said, okay, so that's the good length because his stem is working. So everybody copied the same length of the stem. And finally, once we found much better osteointegrate, well, good, excellent result with uncemented stem, well, there is no reason to keep the stem so long. And you can even go shorter, as we could see the shorter stem, but then you will have to change the way of the way you learn how to work your femur to put a correct stem. So this is another difficulty, and with this stem you really work like you're used to, and it's even simpler, easier, and probably for revision it will be even better. That was my point of view.
Okay, thank you. There is another question from Said Moradi. What is the range of motion of dual mobility in the patient who lose abductor muscles? Nobody want to answer?
What is the question?
I don't understand the question.
The range of motion is you have a complete and full range of motion with dual mobility, even in patients who lose abductor muscles. The problem is the stability in that case, because with the abductor muscle, we know that the risk for dislocation is very high. And in that case, I probably would recommend to use dual mobility and to deliberately lengthen the lower limb. Just tell the patient before the surgery that you will increase the length by probably 1 or 1.5 centimeters to prevent from dislocation. But of course, the patient must be aware of that before the surgery, of course.
Yeah.
But the range of motion is not an issue.
Mm-hmm.
Are there any more questions?
Julien, could you allow me to share screen? I have a picture about range of motion.
Oui, bien sûr.
So this is a good range of motion.
Indeed.
But sorry, it's not a dual mobility. It's a ceramic and ceramic with 32 head. So
Which side? The left side or the right side?
good question.
The right hip or the left hip?
Both.
Both.
She doesn't.
You see this one? Wait, I have to. Let me show. Share screen.
But the debate is still open in.
This is
the left one, yes.
Straight, it's the left one.
Because you do an anterior approach.
Yeah.
So to prevent dislocation. Yeah.
So it's the left one, which is the entire one.
Yes.
Just for fun.
I got a question by WhatsApp from Israel, from Nadav Erlich, regarding the reamers and the cup. While you choose the implant, it should be one by one. I'll let you answer. The adaptation between reamer and cup size.
For the cup, do you mean
What was the question?
I think the question is, what is the diameter of the reamer in regards with the diameter of the cup?
Oh,
It's the same. For me, it's the same.
It's size for size. Yeah.
Size for size, yes.
Yes.
Because it was designed for that.
Exactly. Yeah.
Yeah. There is a press fit between when you ream 50 millimeter, the press fit is 1.2 millimeter, something like that.
For 44.
It's a little bigger.
You need to use the good reamer, not to use another one. That's true.
There is another question from Martin Principato. Do you find in your practice some place for constrained cup cups in revision? That's a question for Professor. We have few professors here.
Olivier.
In my practice, I probably would use one constraint implant a year because I have a quite high volume of hip revision, but it's never it's never the first option. Of course, it's really a salvage option when the dual mobility fails. Sometimes it fails, but I try to avoid a constraint implant because there is a very high risk for high stress transmission and the loosening of the cup and the construct. But I try to avoid that. But sometimes, even if the dual mobility fails, then you have to. This is the last option. You use a constraint implant. But I try to use the less constrained one because there are some there are many designs of constraint implant, and some of them are provide more constraint than others. So I try to use the less constrained implant in case of failure of dual mobility.
You lose range of motion with those.
Yeah, of course, you decrease the range of motion. Yeah.
It's always a salvage surgery, so with very difficult cases, and we use it two times a year. But sometimes when you don't use it, it's not possible to have any stability with even with dual mobility. So it's very, very rare.
For example, when you have a proximal femur resection or something like that, you have no more abductors. Sometimes you need a constraint implant, but it's very, very uncommon and only in salvage situation.
What do you prefer, stem with collard or without collard, and why? This is a question for me, I think.
It's for you, Nicolas.
Well, I will answer with standard stem. Well, I used to use Cori-like stem. My problem was my subsidence, and I was working my femur normally, not too strong, and generally I could regularly have a few millimeters of subsidence in the following months. So to work against that, I've talked to people and they told me you have to work your femur much harder in order to block your stem on cortical bone. So that's what I used to do, and you have some other problems when you do that. So I couldn't really find the good way, and the good way was just to work my femur as usual, but with a collar. And you, in this case, you never have any subsidence, and you improve the resistance in compression by 10 and the resistance in torsion by 3. This is a publication from one of my partners. So there is no side effect of collar. So why shouldn't you use it? With the symbol, it's a little bit different because I really think you almost never have any subsidence. So because the blockage is much higher than in Cori-like stems. So maybe I'm less aware of using a collar with the symbol one, but I'm used to it. So I'm more confident when I have another point of contact, another contact. What is the thought of the others that don't use collar? Why don't you use collar? That's a good question.
In the past, I use always collar, and now with symbol stem, I decrease my use of collar because there is a good press fit in the metaphyseal bone, and when I'm not sure, I do like you because I learned with collar and I continue to use collar, but I don't not use a collarless stem when I don't use symbol stem. So I increase my use of uncollar stem.
Finally, with the symbol, the collar is not is less important than with
less important. I agree.
I use a color with when the people are very old. Sometimes I use a color or more than 100 kilo. I use color because I'm quite afraid, so I use color. I have quite the same indications than Florent and Frédéric. At the beginning, I used more color. Now I decrease this use because I'm more confident in the press fit in proximal femur.
Of the stem. Frédéric, Ludovic.
I got another question from WhatsApp from Argentina. Question for designers. Why did you choose HA coating instead of export or porous coating for the stems? Why HA instead of porous coating for stems?
Jean-Emmanuel showed a great slide about that.
We have both.
Yeah.
We use macrostructure and HAP. We do not choose in between one of. Or I didn't well understand the question. No.
It's titanium porous.
We use a porous. We use a rough surface in the cup and microstructure in the stem, and both have HAP. Is that answer to your question?
There is a long follow-up with hydroxyapatite with corail stem. So we believe in this kind of. So it's a very good option, we think.
Yeah, the study comparing titanium versus titanium plus hydroxyapatite shows that titanium plus hydroxyapatite works better. So that's why we chose this option. There is another question of intraprothetic dislocation with the new implants. So intraprothetic dislocation is more a problem of the stem than of the cup. So the stem, the head neck offset needs to be the best one, and the neck should be polybrillant, je sais pas comment on dit. Should be
highly polished. Should be highly polished, not roof.
And as small as possible, and without any angles. So the
head neck geometry is critical. The head neck geometry is critical to avoid the intraprothetic dislocation. You have the shape of the neck should be round, and the surface should be as smooth as possible. So no roughness, and also the design of the chamfer is also critical on the acetabular insert.
This is a problem that should really maybe not disappear, but almost, because we really understood why there were these kind of problems, and with new implants solve it.
Yeah, I fully agree. I think this problem has been addressed with the modern dual mobility implants.
I think it's over.
Maybe two
stems on there. There is one question that I don't understand. Other companies' stems on head.
I don't understand too.
I think the question deals with a mix between.
I think so.
Between brands. I mean, the question concerns that when you have a symbol dual mobility cup in front of Zimmer or the Pew stem.
Who wants to answer?
I think it's better to use the stem with the cap, but we can, as for other implant, one of the two part of the system, but it's not recommended.
You must be sure that you have the same cone Morse, because there is some company who have a different one. So you cannot put the head on the stem. Yeah. But you must use the same implant from same company. I think that it's better. Yeah.
It's better, sure. So I think if there is no more question, we can conclude this first international webinar. I hope you enjoy the presentation. It was a very good quality of presentation, and thank you for all the panel of all the experts. And I will give to conclude the talk to Ludovic Toledo to end this first webinar, if you agree.
I do. Merci Frédéric. Thanks a lot to all of you. Thanks a lot to all the attendees of this meeting. Once again, I would like to warmly thank you, all of you, the speakers from Argentina, Tunisia, and France and Switzerland. It was a pleasure to follow your lectures. We had a lot of comments during your lectures from the WhatsApp groups in Argentina, in Iran also. So I think your lectures give a lot of interest in our to our attendees. So thanks a lot for the job you made, and thanks very much also to all the attendees that are still online right now. So good night for the French people and Tunisian people. Buenos dias in Argentina, because I think it's not so late there. It is maybe it is the afternoon. Es la tarde en Argentina, no? Et bonne nuit à tous. Merci. Thank you a lot. Hasta luego.
Merci à tous.
Merci beaucoup. Merci.
Merci beaucoup. Merci pour votre participation. Au revoir.
Salut Julien. Merci. La technique a bien.
Merci. Ça a fonctionné.
Ciao.
Ciao, monsieur.
Ciao.
Ciao.